Hi, I'm Deborah Rubens. I'm from the University of Rochester, and the topic of my talk is basically ultrasound for the diagnosis of deep venous thrombosis. We'll be reviewing technique and also findings in DVT. Today we're going to be talking about ultrasound scanning for deep venous thrombosis. And we'll be learning the protocols to perform successful upper and lower extremity venous examinations. We'll become familiar with the roles of compression ultrasound, color, and spectral Doppler as we make the diagnosis of DVT. And lastly, we'll be looking at some of the main pitfalls in venous extremity ultrasound. So to begin with, venous thromboembolism is a very common problem. It affects 70 out of 100,000 patients annually. It is associated with pulmonary embolism 90% of the time, and that's in patients who do have DVT. PE, as you know, causes many deaths per year, and currently for extremity DVT, ultrasound testing is the primary diagnostic method. You can see here a patient who has obvious pulmonary emboli in the pulmonary arteries. Cancer patients are a special high-risk population because the incidence of venous thromboembolic disease is as much as double the general population, and it even increases in patients with metastatic disease, especially in patients who are high risk, including patients with GI malignancies. Sometimes it's because these patients are hypercoagulable, and then often it's because patients have catheters which incite thromboembolic disease on the catheter. Here you can see a patient with a catheter in place, and you can see the clot forming along the margins of the catheter, and then this extends into the axillary vein. Clinically, DVT is important because patients present with pain and swelling of the affected limb. And of course, as we already said, there's an increased risk of pulmonary embolism. Of patients with pulmonary embolism, 70% may have an asymptomatic deep venous thrombus. If the thrombus is from a lower extremity and very small, usually that embolus is asymptomatic. Only 5 patients actually with symptomatic DVT will have isolated cath thrombosis, but of these, approximately 30% will extend into the thigh or popliteal veins, so even cath thromboses are important to make the diagnosis. Again, in addition to acute DVT, DVT can be a chronic problem with recurrent disease in 20% of patients, often in the same leg, sometimes in the other leg, and again, patients who go on to have pulmonary embolism after having had a DVT. In addition, patients who have had a primary event of deep venous thrombosis may develop postphlebitic syndrome, which is valve damage and then development of chronic pain and swelling. And the incidence of this is estimated to be as much as 29% at 8 years after the initial event. So to make the diagnosis of deep vein thrombosis, first we need to remember our anatomy. So which lower leg vessels actually can harbor a deep vein thrombosis? Well, basically, the deep veins are anything that go through a muscle. So the iliac vein, the common femoral vein, profundifemoral vein, and the paired deep calf veins are certainly qualifiers. In addition, the muscular veins, including the gastrocnemius and soleus, plus unnamed tributaries that go through the muscles, are also deep veins. And in addition, the greater saphenous vein, which is actually a superficial vein, is considered harboring clot, which can be considered as significant as deep venous thrombosis in the distal 2 centimeters. And that's because this clot has the same propensity to get into the deep venous system and go to the lungs as something which actually originates in the deep venous system. So clot in this location is treated as deep venous thrombosis. One more thing about normal anatomy, you can remember from medical school or from any other anatomic course where you've taken, that the arteries and veins are labeled as the superficial and deep femoral artery and vein. However, the superficial femoral artery and vein, which is basically the main vein that's draining the leg, is actually now called in our nomenclature the femoral vein, because some clinicians, if you use its anatomic name, will ignore the fact that there's clot in this location and believe this vessel is not really a deep vein. So the calf veins, the way we look at those is we want to scan the paired veins with graded compression and identify the adjacent artery as needed. The tibio-perineal trunk, this is just anatomic information, is actually the confluence of the perineal and posterior tibial veins. It's this little portion right in here, which occurs before the confluence with the anterior tibial veins, which occurs just below the popliteal vein. We want to scan the calf veins in their entirety in addition to scanning the vessels above the knee. And just to show you that you can see these calf veins, here is the artery, here are the paired posterior tibial veins, which you can see coapting completely as we do graded compression on this little area of the popliteal. The muscular calf veins, as I said, are also deep veins. Remember, the gastrocnemius veins will be in the gastrocnemius muscle. They often can be identified by an accompanying artery within the muscle, and they will enter the popliteal vein. And you can see here on the sagittal image, this is the more superficial muscle group here. The soleal sinuses are in the soleal muscle, and they're in the deep vessels, the deep muscles, which are adjacent to the tibia. There's no paired artery here, and they will empty into either the posterior tibial or perineal veins. These are fairly small. There are some normal variants to be aware of. The femoral and popliteal veins are commonly duplicated, at least 20% femoral duplication and 30% popliteal duplication in normal populations. It's important to recognize this because in patients who have duplicated femoral veins, the incidence of DVT is much higher, rising to even 38%. You can even get triplicated segments, and as we said before, unnamed muscular branches may occur. So in this image here, you can see the paired femoral vein in its mid portion. Note it's combined up here proximally and actually will merge down here distally. Why is this important? Because you want to be sure to look for these duplications. Here's a patient with an artery, a vein which is mostly collapsed, and over here a vein which has thrombus within it and is not collapsing. As I said, a triplicated segment can occur. Here's just an example of a patient with a triplicated segment. You can take spectral tracings from all three and show that, yes, these are all venous waveforms. But easier is the compression examination over here, where you can just look at the vein, the vein, the vein. Here's the adjacent artery. When you compress, all the venous structures should disappear and only the arterial structure remains. So the compression technique is the mainstay of our diagnosis. You want to use a high-frequency linear array transducer. This is a grayscale examination, so you want very good image quality with your grayscale. You compress every centimeter from the common femoral vein to the popliteal trifurcation, or to the tibial perineal trunk and the anterior tibial vein. And then you'll continue in the calf through all the paired veins as well. And the mainstay is that the vein walls should coapt completely. If they don't, be suspicious that you have a DVT. Here's an example of the common femoral vein. You can see it here collapsing completely. The artery which is next to it does not collapse, and you can see the adjacent arterial pulsation as the vein collapses. You should still be able to see the artery right there. One pearl here is that if you're compressing in the thigh, sometimes the bone gets in the way, so you can use one hand behind the medial thigh and help compress the femoral vein in the adductor canal. You want to scan the groin and the proximal thigh from the anterior aspect. In the mid-thigh, you'll go medially to be on that femoral vein, and in the distal thigh, as the vein dives deeply, you may need to go posteriorly. And you certainly need to go posteriorly behind the leg to get to the popliteal vein. If you want the veins to be distended, it's good to have the patient's head elevated, and if you need to, have the patient dangle his or her legs over the side of the bed, and that will help you distend the calf veins to better see them. So we tend to use just compression still images. It's a quick, easy way to record. So the left side of the image is the distended vessels, and as we compress, you can see that the veins go away. This is just a little bit of muscle here, and the artery is left behind. Again, vein and artery, artery left behind, and that goes all the way through down to the popliteal. So the diagnosis of a DVT is made by a non-compressible segment in grayscale. The clot will expand the lumen, and also if you're using color, it will displace the flow in the lumen. So here we see a patient in long axis. Here's the popliteal vein with a thrombus within it, and you can see again on transverse, the popliteal vein is not collapsing. It's important to do the compression and not just rely on grayscale, because here you can see that there's a patient with an anechoic acute thrombus in the common femoral vein. Very difficult to see just on the grayscale alone. So here's a quiz case for you. Is this a deep venous thrombosis or a superficial vein thrombus? You can see here is a vessel and it's distended, and here you can see the clot within it on the grayscale. And when the compression is performed, you can see there's an area here that is not compressing. And you can see here that the sonographer labeled this as a superficial vein, but it's actually not a superficial vein. It's a muscular vein because it's traveling in the muscle. Here is the subcutaneous tissue up here. A superficial vein would be in this layer of the tissue. So this is a muscular vein, and this was a DVT, and this patient has pulmonary emboli, so an important clot. When do we use color? Well, first of all, the color Doppler technique I think is useful to find some deep compressed veins in patients who have a lot of edema or swelling. You can help by squeezing the calf or using a Valsalva release to increase the flow, and that will help you see the vessels with color. This is not helpful diagnostically in terms of augmentation. If you, for some reason, cannot compress the patient, for example, a patient who has severe contractures or has a great deal of pain or can't tolerate compression, you can actually use color Doppler alone, especially above the knee. And that is basically for proximal DVT between the thigh and between the groin and the knee in the thigh vessels. So here's an example of a patient who had contractures. You can see here's color flow in the common femoral vein, and in the femoral vein here, this is an old scan, so we were still using the wrong terminology here. But this is a patient where we could not get in to actually compress with grayscale. This patient is post-gastrectomy, and we see calf clot detection with both grayscale and color. Sometimes it's a little hard to see things with grayscale. If I didn't have arrows here, it might be hard to see that there are two vessels here. They both compress, but down deeper, you can see here there's actually one that's not compressing. And if you want to look on long axis, that can be useful to show you the length and extent of the thrombus. Color is helpful sometimes to show the proximal extent of clots, especially when they're in the groin and above, because you cannot always compress the common femoral vein once it dives deep into the pelvis to become the external iliac vein. So this is a patient who has a common femoral vein clot, and as we go up above it again, we're able to see that it does not extend into the external iliac. The vessel is patent above this clot. So question here, another quiz case for you. Is this normal or abnormal? This is the femoral vein in its upper portion, and the mid portion looks fine. Here it is inferiorly, and we can see on here again, left-hand side, two vessels, everything compresses. And of course, does this look normal? The answer is yes, but we haven't completed our exam because this is a patient with a profunda femoral vein clot. So here we have a large clot in the profunda femoral vein, and this is a deep venous thrombosis. You can see it right here sitting nicely, partially occlusive and ready to head north if it wants to. Some color Doppler pitfalls. If you rely on color Doppler alone without compression, you can actually write over the thrombus if the color settings are too high, or if you have a partial volume effect. If you use the color only in the long axis, you may miss where the clot is. So you want to make sure you use color in the transverse plane as well as in long axis, especially if you're using color alone. Again, evaluation of the proximal extent into the iliacs may be difficult if patients are very large or have a lot of gas and you have a poor acoustic window. So just an example again, here's a pitfall, a patient who has color bleeding over the posterior aspect of the vessel. And this is the typical place where color bleeding occurs, so to make sure your settings are okay, you want to always check the posterior margin, because you can see here anteriorly the color is fine, but posteriorly there's too much color. So this color gain is set too high. Here's a patient where everything looks okay, and what's the pitfall here? Well, we moved just a little bit to the side, and all of a sudden, ooh, there's a big thrombus sitting in here. So if you are not using compression, you want to be sure not just to use long axis color in one part of the vessel, you have to sweep from side to side, and especially you want to go transverse, because you can see here is a very small thrombus. In terms of its dimensions, it's sitting only in the middle and posteriorly on the vessel, and if you image through this part in long axis or this part in long axis, you'll miss this entirely. Here is a patient where we had an initial exam. We can see this looks like there might be a little bit too much color here, but in addition, the compression exam was probably not done as critically as it should have been, and this was missed on color as well as on compression, and we brought the patient back and found this clot just 6 hours later, and you can see this is a very small length clot, but it's a very significant clot, again, sitting just at the junction and hanging loose in the middle of the lumen, ready to go up to the lungs. So this is the pitfall of a small thrombus. You want to be sure on your compression exam, really be meticulous about going every centimeter so you don't miss this. And again, use that transverse image on color to make sure that you're not missing the clot here. You can see this clot here on the adjacent CT looking the same as it does on the ultrasound, but again, it's only 1.5 centimeters long. When do we use spectral Doppler? Well, the spectral Doppler waveform is very useful to look for abnormalities above where you can actually directly compress. So a monotonous ipsilateral waveform will indicate more proximal disease, either within the vessel, intrinsic, or extrinsic, adjacent to the vessel. And if you have a bilateral abnormality, that means either you've got problems in both iliac veins or in the IVC or around those vessels. So just some examples here on the normal common femoral spectral waveform here on the right and on the left. You can see good pulsatility here, returning all the way back to baseline. Even if it's only halfway back to baseline, that's certainly good enough to be called normal. An abnormal waveform is something that's monotonous, that goes less than halfway back to the baseline, as this patient does. And there is one common physiologic entity which can cause this. In this patient, we did something, we changed the position. You can see here it says decubitus right common femoral vein, and you can see that the pulsatility and the variability came back. And here with the Valsalva, you can see a good obstruction, if you will, of the waveform as the patient holds her breath. And this is a patient who was pregnant. So the weight of the uterus basically was compressing her IVC as well as her iliac vessels. And so when we turn her off of her IVC onto her left side, we can restore the flow in her veins. So how significant is this as a clinical problem? Well, when we did our review of our patients, we found that out of almost 3,000 patients, about 124 did have a monophasic waveform, and we had correlation with CT or MR in a good majority of those. We found about 40% of them actually did have DVT involving the iliac veins, so a high incidence of that. About 20% had extrinsic compression, some had intrinsic narrowing, and then unfortunately in a fair percentage there was really no explanation for why we had a monophasic waveform. But just some examples of patients who have abnormalities with their monophasic waveform. Here's a patient with a unilateral abnormal right side. You can see the phasicity is normal on the left, returning to the baseline. And on this patient, when we went, you want to try to see as high as you can. And here you can see on the right side, the transverse iliac, you can see that you cannot see a waveform. You can't see any color in here in this vein, whereas on the left side you could see color, and when we turn longitudinally on the right side, there is a large thrombus sitting higher than we would normally have performed our ultrasound examination had we not looked for this monophasic waveform. Bilateral abnormalities, here's a patient with monophasic waveforms bilaterally. You notice that these vessels will still compress, so it's the waveform that's going to clue you into the fact that there's something happening up above. And in this patient, it happened to be retroperitoneal adenopathy in a patient with uterine carcinoma. A unilateral monophasic waveform, again, can be from extrinsic compression, as in this patient. Right side is normal, left side very abnormal. You can see the vessel here normal on the right. On the left side, this left iliac vein is going to be compressed by this necrotic adenopathy from this patient with bladder cancer. So monophasic waveforms are very significant. They are a reliable indicator of proximal obstruction. 40% of iliac thrombosis was the cause in our series, and that does have the same clinical significance for pulmonary embolism and post-phlebitic syndrome as a thigh DVT. So it's very important to look for these, and if you don't have this in your protocol for your examination, I encourage you to add it in. The incidence of iliac vein is higher than it used to be expected. Usually we thought it was 5% of DVT, but some newer studies think that we are seeing about 18 to 20% of lower extremity DVT is actually caused by iliac vein clot. So important to remember that and include it certainly whenever you have monophasic waveforms. If you can't see as high as the iliac vein and you can't find the cause by ultrasound, then you need to enlist either CT or MRI to look at the proximal vessels and the surrounding soft tissues. Let's turn now to upper extremity DVT, which is actually an important cause of morbidity in patients as well as pulmonary embolism. So this is just an example of a line-induced clot in the right axillary vein. So is it the same as lower extremity DVT? It used to be taught that upper extremity DVT was not important. For one thing, it was very rare, small percent of all DVT. I think these numbers are climbing now considerably because we have so many catheter-induced clots. Primary DVT is related to enlarged muscles, actually, which will occlude or impress upon the underlying veins, or it can be due certainly to patients with a hypercoagulable state, and it's very rare. Secondary upper extremity DVT is quite common, and this is related to these central lines or peripheral venous catheters or even pacemakers, which induce thrombus upon them. And up to 25% of patients with lines actually will form clots. So pulmonary emboli are seen in anywhere from 12 to 36% of these patients, depending on who you read. And the mortality from this PE is actually the same as in patients with lower extremity DVT as the associated cause for the pulmonary embolism. So in primary upper extremity DVT, there's about a 6% incidence of PE, but again, in these patients with high risk and hypercoagulable factors, the incidence of PE starts climbing to 13%, and in catheter-induced DVTs, the incidence of PE in association is as high as 17%. So you can see that these high-risk and catheter-induced patients certainly do have high risk for PE. What's the clinical presentation? Well, these patients, unfortunately, not all have clinical symptoms, only 60%, and the symptoms are quite different. So they can present with pain or swelling or erythema, dilated superficial veins, a cord, neck or shoulder pain, facial swelling, and actually less than 50% of patients with symptoms actually will have a documented DVT. So this is a difficult clinical diagnosis. In the lower extremity, we talked about compression being the mainstay. In the upper extremity, not all of these vessels can actually be compressed. So the internal jugular, the basilic, the brachial, the axillary, and the distal subclavian veins where we can do compression, that's still the mainstay, just as in the lower extremity. However, behind the clavicle, and behind the clavicle and sternum junction, we need to be using color to see the subclavian and brachiocephalic veins respectively. And in this case, if you don't see flow in those areas, that is considered abnormal. The spectral Doppler will document normal variability with the respiratory and cardiac cycles. However, spectral Doppler alone can be insensitive to clots because in the upper extremity we develop collaterals fairly quickly, and you can see nice variability in these collaterals as well. So the accuracy of upper extremity DVT, not as good as we are in the legs. There's a large range of sensitivity, but the specificity, if you see a clot, is very high. And a prospective study compared to venography yields basically a specificity and sensitivity of about 82%. Again, our compression exam is the most specific, incomplete filling on color is the next, and then lastly, the spectral waveform analysis is only about 50%. So just a reminder for the normal anatomy, the cephalic and basilic veins here are superficial veins, so a lot of our lines are placed in here, in the cephalic or certainly in the basilic. So the clot that occurs on those lines is considered a superficial clot until it travels into the axillary vein. The deep veins include the internal jugular, certainly the subclavian, the axial, and the paired brachial veins. The normal compression examination is the same as in the legs. You can see here's the jugular vein and here's the carotid below it. When we compress, only the carotid is left. The same thing in the axillary system. The axillary vein compresses completely. The artery is the only thing left. Same thing for the brachial veins, the paired brachial veins here. And here's the basilic vein over here. It goes away completely. An example of thrombus here in the subclavian vein you can see is an area which is not compressible. And again, on the color you can see partial obstruction of color flow secondary to this marginal thrombus. The normal spectral tracing is similar to what we saw on the legs, especially if you're further out in the arms. You can see its pulsatile comes back towards the baseline. Sometimes you'll see a little bit more variability, and some of that has to do with the cardiac pulsations that are also reflected in these vessels. But you can see nice pulsatility all the way from the axillary vein through the subclavian vein and into the brachiocephalic vein here. All right, so is there a DVT here? Well, we can see that there's color flow here, and we're in the subclavian vein, so we're beyond the point where we can have compressibility. But when you notice this waveform, this is not as variable as I showed you on the previous slide. And when we look more centrally, here is the brachiocephalic vein here with a nice pulsatile waveform, and sure enough, in between the two, where you'd expect it, is a clot. So this is sort of analogous to what we were seeing in the leg. The part that's closest to the heart still has the nice pulsatility, and then that's interrupted here by the clot. Notice that there's a collateral already here forming alongside, and then in the more distal vessel you can see this more monophasic waveform. If this were emptying better via a collateral, this may not show that monophasic waveform, and it might actually be fairly pulsatile. Just an example for the upper extremity, is there a PICC line DVT? And here in the subclavian vein you can see nice pulsatility as well as in the axilla. And notice here is the line. You can see a little bit of flow around it. And just to be aware, again, your color flow can sometimes obscure the clot. You really do want to look at the grayscale carefully along the clot, along the line. And therefore the grayscale here helps to make the diagnosis, not the spectral and not necessarily the color. You want to be sure of the grayscale as well. Notice the nice normal lumen that you can see, just a small amount of it on this deep side of the catheter. So here's just another example here, a patient with a subclavian vein clot. You can see here is the monophasic waveform, and you can see a lot of thrombus here sitting along the catheter in the medial aspect of the vessel. The important thing to remember is do a complete examination, because sometimes these patients will have other clots in other places, and there's an additional thrombus in the right internal jugular vein, so make sure that you examine both the internal jugular veins in each patient. What are our main pitfalls? Well, Certainly there are the technically inadequate examinations when patients are very large or if they have tense and swollen limbs that we can't compress, and that could lead to a false positive diagnosis, so therefore we want to use color in those patients. These duplicated segments, if only one is thrombosed, you may miss it because the other one will be normal. And just remember the nomenclature issue, that distal saphenous vein and those muscular calf veins really are treated as deep venous thromboses. So just examples here, a DVT pitfall, we can see an artery and a femoral vein here, and what do you think the pitfall is going to be? Well, remember the duplicated segments, so when we actually look a little more carefully and a little bit deeper, here is a large vessel here deep to this artery, which is actually a completely occluded femoral vein, and so we want to make sure to think about that and recognize that there is a large grayscale clot here. Again, here's a patient with a common femoral vein and a popliteal vein with sort of a monophasic waveform, so and a very nice pulsatile waveform here in the common femoral vein. So remember that you need to examine all the segments and don't skip anything, because here is an isolated clot actually in the femoral vein. And again, there's a duplicated system here. Don't ignore any segments, because you may have isolated clots in the thigh without associated clots in the calf. Again, a patient who has a color Doppler pitfall, we can see the artery here, we can see what looks like a vein here, but this is very far away from the artery, and so I've labeled here, this is the popliteal vein actually sitting back here. So there's a large clot in the popliteal vein. You do not want to mistake a collateral for a patent vessel. And the distance between the two of these is actually the most useful thing to recognize that you're dealing with a collateral rather than the native vessel. Okay, so an unknown for you is this a deep vein or a superficial femoral vein thrombosis? And I'll give you the clip again. So we're located up in the common femoral vein here, and this is a large clot which is in the saphenous vein, and we will report this as positive for a deep vein thrombosis because the greater saphenous vein is treated as a deep vein in its cephalad portion. In those very distal 2 centimeters, or the most cephalad 2 centimeters of the saphenous vein, you want to make sure that the clinicians treat this patient as a DVT. Again, here's another example, patient DVT or superficial venous thrombus. Here's a clot again that you can see here. It's only in the saphenous, but when you look carefully with color, you can see that this clot is actually protruding into the common femoral vein. And again, this is the risk of those saphenous vein thrombi, that they actually enter into the common femoral vein and do become deep vein thrombosis. What about this patient? Here is a patient who had a thigh sarcoma, so he's got a cancer and he's at high risk. And when we did the initial study, the patient had diffuse leg pain and the sonographer reported this as negative. So what's missing in this exam? And that's sometimes the hardest thing to recognize. And you can see here the posterior tibial vein has 2 vessels. The perineal vein has a little color flow here, and the anterior tibial vein you can see flow and a spectral tracing from something up here. So what's missing is the perineal veins, of course, are paired, as are the posterior tibials and the anterior tibial veins. So we brought the patient back and repeated the exam, and we looked at the perineal veins in particular, and when you do that, you can see here there's absolutely no compression there. You can see one vessel here, but deep to it is another vessel which has a clot within it. So don't omit that grayscale compression exam, and make sure that you identified paired veins in all of these 3 calf tributaries. What about chronic DVT? That's a pitfall for us. We can characterize that if we see focal or diffuse wall thickening, because of course these patients don't need to be treated. So here's a patient on initial exam. You can see a clot which is expanding the lumen, and then 3 months later you can see that this clot is much smaller and the vessel walls actually are contracted towards one another. So this could be read out certainly as a chronic DVT. You're more certain of this if you can see more contraction of of the vessel or if you see calcification or webs or scars. So here's a patient actually with some slightly calcified or a very echogenic web within the vessel. So this is certainly a chronic DVT. This patient does not need to be anticoagulated. Here's another patient with a clot that has calcium in it. So this again should be a chronic clot. Notice here again, the color can obscure this. You want to make sure you look with grayscale as well, and that way you will see the clot as well as see the calcium within it. And lastly, you always want to think about alternative diagnosis. Always image where it hurts. So a patient with left leg pain and swelling, this happens to be a large Baker cyst, which certainly can mimic the symptoms of DVT. Here's a patient with arm swelling, and we found an abscess with gas within it. And so there are many other causes of alternative diagnoses, certainly masses, tumors, ruptured muscles, etc. So always look where it hurts to make the diagnosis. What about serial ultrasound? Well, that was previously recommended at 1 week in all patients. However, now we basically do not recommend that if the first ultrasound is negative, unless the patient is very high risk for clots. It is safe to withhold anticoagulants if you have a normal initial examination and do serial ultrasound. And lastly, follow-up is unnecessary unless the patient has persistent symptoms. And if the patient does have symptoms, we would encourage follow-up examination in about 5 to 7 days. So in conclusion, ultrasound is highly accurate to assess lower extremity and upper extremity DVT. Grayscale ultrasound is central to the diagnosis. We use color to facilitate the grayscale exam, especially where compression cannot be performed, and that's particularly in the upper extremity exam. And lastly, we want to use spectral Doppler in the bilateral common femoral veins to assess for the proximal extent of clot and to look for proximal obstruction, and also in the upper extremity to look at the central veins. Remember to beware of duplicated systems and collaterals that can be confusing and lead to false negative diagnoses. Be sure to image where it hurts, especially in the calf, in order not to miss those muscular clots or other causes of the patient's symptoms. And remember, a technically adequate negative DVT exam in the leg does not necessarily require follow-up if the patient does not have persistent symptoms. So thank you very much, and I hope you found this helpful, and I encourage you to use ultrasound as much as you can to examine your patients with leg and arm symptoms.